topic of discussion is to focus on the clinical practice through latest data. And we are talking today on pulmonary embolism, antithrombotic monotherapy, carotid artery endarterectomy and carotid artery stent, and others. So the takeaways from today's discussion would be on percutaneous treatment of pulmonary embolism and efficacy of antithrombotic monotherapy according to revascularization. So let's go one by one. So these are the topics that we will go through one by one. Of course, these are the takeaways, but let's dig deeper into what we are learning today. So the first thing, efficacy of antithrombotic monotherapy according to revascularization. We found that rivaroxaban monotherapy had favorable safety and efficacy outcomes over combination therapy in those patients who had high thrombotic risk, who had a history of prior revascularization in this post hoc analysis from the FI trial. So we all know that when patients have high thrombotic risk, there is increased ischemic events. So should we give them higher anti-ischemic therapy? So that is where this study says that rivaroxaban monotherapy has been shown to be both safe and efficacious in reducing ischemic events without increasing the risk of significant bleeding. Now, talking about the second issue, which is the state of the art from neurointervention, percutaneous interventions for pulmonary embolism. We know pulmonary embolism is a serious issue. It ranks third after stroke and myocardial infarction in terms of acute events and major cause of death. And so far, what we understand is anticoagulation is the treatment of choice, and it remained to be the mainstay treatment for acute pulmonary embolism, whether it is low risk, high risk, or whatever may be the presentation. Systemic thrombolysis is underutilized, and it is reserved only for patients who are categorized as high risk pulmonary embolism patients. And systemic thrombolysis has many limitations. There is fear from the physicians, and there is also efficacy issues, and because of which there were attempts to find out different treatment strategies. That is where percutaneous catheter-directed therapies have emerged as alternatives to make the prognosis of pulmonary embolism better. These techniques, which are currently increasing their popularity, they have high procedural success rate to close to 87% and seems to be changing the prognosis of patients who are having acute pulmonary embolism. Now, how do we treat pulmonary embolism is the focus of discussion. So first, we need to understand the pathophysiology of acute pulmonary embolism. So what is pulmonary embolism? What happens when there is a pulmonary embolism? There is a deep interplay between pulmonary and systemic circulation, which lead to a wide range of presentations, which can be subclinical to cardiogenic shock. So the obstruction is a mechanical, and because of mechanical obstruction, there is reduced blood supply, reduced cardiac output, and it adds to pulmonary artery vasoconstriction, which also leads to systemic circulation, compromising the systemic circulation and hypotension. So if you look at the flowchart, the interplay between the systemic circulation and pulmonary circulation, release of cytokines, surfactant loss, which leads to atelectasis, and pulmonary flow redistribution, which ultimately leads to arterial desaturation. And from the systemic circulation side, because there is decreased preload, because of the reduced blood supply, and also because of LV-RV asynchrony, there is reduced cardiac output overall. So the combination of reduced cardiac output and arterial desaturation leads to the so-called hypotensive shock, which is a problem and the gravest presentation of acute pulmonary embolism. Now, whenever we diagnose a patient to be having pulmonary embolism, the first step that we need to do is to risk stratify these patients into mild, moderate, or severe. So for those patients who are having massive pulmonary embolism, how do we go forward? If you look at this flow chart, the first important thing is to see whether the patients have any contraindications to receive anticoagulation. If the patients have contraindications to receive anticoagulation, then we put an IVC filter to prevent further progression of the thrombus from the deep veins. And then you look at hemodynamic stability of the patients. If patients are hemodynamically unstable, instability is there, these patients are the so-called high-risk patients, and for them, there is evidence to say that thrombolysis is beneficial. So you administer systemic thrombolysis, and if there is some contraindication, then we try to look whether we can do catheter-directed thrombolysis or sometimes do surgical embolectomy. These are surgical embolectomy and systemic thrombolysis are class 1 recommendations for patients who have massive pulmonary embolism and hemodynamic instability. Patients who are relatively stable, they are okay. We need to look at their PISA score, pulmonary embolism severity index. There is a score which you also have online calculators, and based on that you classify them, and you try to look for other evidence to see how aggressively we can manage them. So if any of those other criteria are there, like presence of RV dysfunction on echo, elevated cardiac troponins, these are relatively higher risk in comparison to relatively higher risk. So you classify them into intermediate high risk or intermediate low risk. And for again, you try to give them the benefit of doubt by giving thrombolysis. So these patients, you need to monitor them closely. And if they are deteriorating, then we have to be ready to thrombolyze them or do catheter interventions or surgical embolectomy to relieve the mechanical obstruction. Those patients are who are relatively stable and whose PESI scores are low. They fall into low risk, and for them probably anticoagulation alone should be sufficient, and they gradually make a recovery and they can be discharged home. So the problem or the issue with systemic thrombolysis, it is considered to be the primary treatment for patients who have high risk pulmonary embolism. We all we all fear the bleeding associated with thrombolysis. So it has an increased risk of about 10% of bleeding. And in patients with high in the setting of high risk pulmonary embolism, the benefits always should outweigh the risk associated. So we have to make a decision what is the benefit that the thrombolysis offers. The PITO trial demonstrated that there is decreased risk of hemodynamic decompensation with systemic thrombolysis, and it was not accompanied by a reduction in 7-day mortality. And we all know that there is also an increased risk of severe extracranial and intracranial bleeding. So all that effort that we do to relieve obstruction can be problematic with bleeding, which we do not want our patients to have. What if we do surgical embolectomy where you go directly dig in and remove the thrombus and relieve the mechanical obstruction? So it is considered to be class 1 recommendation. It is a potential treatment for those patients where thrombolysis is contraindicated or thrombolysis has been given, but it did not succeed. So those patients we have to see. So surgical embolectomy will be a choice for those patients who have high proximal thrombus burden. There is a thrombus in transit. Sometimes patients having paradoxical embolism, and also those patients who are hemodynamically unstable. And it has been showed that surgical embolectomy, after relieving the mechanical obstruction, it can improve the outcomes. It can improve RV function, almost similar to thrombolysis, and it had comparable 30-day mortality and 5-year survival rates. So this is an option, and we need to involve our surgeons to help recover our pulmonary embolism patients. Now we are in between the systemic thrombolysis and surgical embolectomy. We all understand that surgical embolectomy most of the time may not be available due to various reasons. So we also need alternative therapies. This is where catheter directed therapies have come into picture. So these involve techniques where there are endovascular techniques which can disrupt, fragment, or can remove an occlusive thrombus. And they can also deliver reduced doses of thrombolytic agent, which not only lyse your clot and with reduced risk of bleeding, which we all fear. And the procedure success rates are close to 87% as per the latest data, without increase the risk of major bleeding issues. So what are the devices that we have? So there are essentially two, which is either catheter-directed thrombolysis, the so-called CDT, or mechanical thrombectomy. So mechanically, when we are doing thrombectomy, we can either do thrombus fragmentation, we can do rotational thrombectomy, or rheolytic thrombectomy, and aspiration embolectomy. So what are all these methods? We will understand. So broadly, these are the 4 options that we have for acute pulmonary embolism. 1, we are lysing a thrombus in situ by locally administering the thrombolytic agent. 2, we are aspirating, we are sucking out the thrombus, which is obstructing. 2, we can, third, we can do ultrasound assisted thrombolysis. We are breaking down, fragmenting the clots, and then we can extract it. Or you can do rheolytic thrombolysis or thrombectomy, where you are breaking down the thrombus with a high pressure jet. All these options are currently available in the armamentarium for an interventional cardiologist to help the patients recover from acute pulmonary embolism. So how does a procedure undergo? What is the procedure for catheter-directed thrombolysis? So we pass a dedicated side hole catheter whereby large dose can be delivered locally, and a low dose of the thrombolytic drug is directly injected into the artery where the thrombus is sitting. So the drug actually acts on the thrombus and does the local thrombolytic action. So the ultrasound assisted thrombolysis can combine both the actions, which is you are also giving not only thrombolysis, but you are also using ultrasound energy to break down the thrombus. Ecosonic endovascular system is the catheter, which has two lumens, one which contains a filament equipped with multiple ultrasound transducers emitting high frequency, low energy ultrasound waves, which help in breaking down the clot, and other with multiple holes along the length to deliver the thrombolytic agent. So the ecosonic endovascular system, by using this catheter, we can use the two methods to deal with the thrombus. Ecosony is FDA approved and it is available in 5.4 French for Ecosonic and 7.8 French for Ecosonic Plus. And these are currently available. Thrombus fragmentation and rotational thrombectomy. So thrombus fragmentation with a pigtail catheter is the most basic, the poor man's choice, and it is widely used due to its simplicity and low cost. These techniques are helpful in those patients who are hypertensive, where you do not have much time and you have to act fast. And this is something that you can do in a local setup as well. Rheolytic thrombectomy, here the angiojet device. Angiojet device is a rheolytic system which uses pressurized fluid to disrupt blood clots, and it also creates a vacuum to actively remove the debris which is created, and with the possibility of also a thrombolytic agent because of the high pressure jet that we use. Rheolytic thrombectomy was associated with higher incidence of bradyarrhythmia because of the vagal reaction, and FDA currently has issued a black box warning regarding the devices used in pulmonary embolism treatment. So, though it was quite popular, but it is now losing the popularity because of the bradyarrhythmias, because of the vagal activation. Aspiration embolectomy, it aims to reduce the hemodynamics. You are mechanically removing the clot by system is a large lumen aspiration device, which includes a large bore aspiration catheter and a 60 ml aspiration syringe and 3 self-expanding nitinol mesh discs. So these discs are required in up to 25% of cases. By using these discs, you can reduce the amount of blood loss which normally occurs because of suction. So the Indigo system, which is the newest in the system, is the smaller, more flexible profile, which is connected to a continuous suction vacuum system. And it has a separate wire with a soft dedicated tip. With the help of this wire, if there is a occlusion with the wire, we can remove that clot which is obstructing the suction. And the soft dedicated tip at the catheter lumen can also disrupt the thrombus. By using the Indigo system, not only are we able to suck out the clots, but we are also able to reduce the amount of blood that we are sucking it out. So use of blood will be slightly less with the use of the Indigo system. Practical aspects and for percutaneous treatment, the evidence and outlook. The most important thing for the success of catheter-directed interventions is the timing. Early interventions within 24 to 48 hours have better efficacy and safety compared to delayed interventions when patients have started developing the shock. European Society of Cardiology recommends initiating the treatment within the first 60 minutes of diagnosis or at the max 90 minutes if the diagnosis is made in a center that does not perform percutaneous treatment. So the guidelines almost are similar to what we are dealing with an acute MI. So the earlier, the better before the hemodynamics alter. Lot of evidence to support. There are many key studies here from Ultima, Seattle 2, a lot of these things, both follow-ups from 30 days to 90 days and all the data trying to again comparing anticoagulation versus catheter-directed therapies, and currently the evidence, what we understand that they are the systems being compared. So the take-home message being percutaneous catheter-based therapies for pulmonary embolism are showing promising advancements as an alternative to the traditional treatments, that is systemic thrombolysis and surgical embolectomy. And current guidelines do not recommend them as first choice for any pulmonary embolism. And development of a pulmonary embolism treatment network can facilitate the efficient and appropriate transfer of high-risk patients to high-volume centers. And by using them in appropriate candidates, it can improve survival when you use this therapy as a priority in those high risk patients. That is about pulmonary embolism. The next topic that we are discussing is about 30-day outcomes of carotid endarterectomy versus carotid artery stenting in asymptomatic and symptomatic patients. And this is a propensity score matched analysis. So this study, the aim was to compare the 30-day outcomes of stroke, transient ischemic attack, acute myocardial infarction, and death with propensity match groups for the two groups, which is carotid endarterectomy and carotid artery stenting in patients who are having both asymptomatic and symptomatic carotid artery disease. It's a retrospective observational multi-center 1,110 patients, and propensity matching was done, which produced 269 distinct treatment pairs. The primary endpoint, as I mentioned, 30-day risk of stroke, TIA, acute MI, and death. And the secondary endpoint was the technical success and the hospital duration. The results, if you look at the amount of the baseline characteristics, matched versus unmatched, you can see there is a propensity matching of few people. The curve, the dots are either way, but matched people are few. So among them, all the 6 stroke events were minor, and they were registered among asymptomatic patients. 2 had been treated with carotid endarterectomy and 4 with carotid artery stenting. 3 of the patients who had carotid artery stenting, they deployed a distal filter for cerebral protection. Technically, the success was 100%, and the hospital stay was significantly shorter for asymptomatic patients treated with carotid artery stenting than those who were treated with carotid endarterectomy, that is surgery. What about 30-day outcomes? So 30-day outcomes associated with endarterectomy and carotid artery stenting after propensity matching scoring. So if we see all the patients, close to 538 patients who were studied, few were asymptomatic and many were asymptomatic, few were symptomatic. And if you look at the numbers, the stroke, major stroke was almost negligible in both the subsets. Minor strokes were there totally in 6, and this number we already mentioned. Then transient ischemic attack, acute MI, not much difference. Death, stroke, and death as a combination, hospitalization. Patients who are having carotid endarterectomy, their hospital duration was slightly longer compared to those patients who underwent stenting, understandably, because with angioplasty, your hospital stay is relatively less. So what is its impact on daily practice? It's a large summary, but I believe this deserves attention. So I will read it out. So previous large-scale randomized trials established the superiority of carotid endarterectomy over medical management in patients who are having carotid artery disease. And guidelines reserve carotid artery stenting for selected patients who are considered to be high surgical risk. So patients treated with carotid endarterectomy or carotid artery stenting are different according to their baseline risk, both clinical and anatomical variables, and limiting any retrospective comparison of the two treatment techniques. And the propensity score matching analysis accounts for differences in treatment populations, creating a pseudo randomization. So matched pairs can then be compared in a similar way to randomized groups in prospective control trials. And so this propensity match analysis of endarterectomy versus carotid artery stenting for treatment of extracranial carotid artery stenosis based on differences in baseline comorbid features and lesion characteristics suggests that carotid artery stenting is not inferior to carotid endarterectomy in terms of 30-day composite of stroke, myocardial infarction, death rates in both symptomatic and asymptomatic patients. So this is what this propensity matching helped us understand, that stenting is non-inferior to endarterectomy, though the guidelines still say that carotid endarterectomy is superior.
Thank you, sir, for the wonderful presentation. So now the forum is open for discussion. So we would like to start with Dhal, sir. So if you can.
So very interesting roundup of the Intervention Journal that we've had this time. and very exciting field. It's a new frontier once we get into the therapy with devices for pulmonary embolism. We all understand that it is a major killer. Until now, all that we had was possibly thrombolytic agents. So it's a little counterintuitive, because the entire world, on one side, we are happy to handle a lot of low risk or moderate risk pulmonary embolism with oral NOACs, and on the other side, we want to have more and more catheter based devices. But the real benefit is that some of the very sick patients who are not going to benefit with thrombolysis would be at risk of dying from pulmonary embolism. In fact, I came across this very nice suggestion where when we look at all these devices in order, and we say, okay, thrombolysis, catheter-directed thrombectomy, and finally ECMO. And they say that possibly the game changer in salvaging life would probably be ECMO first, and all this later in the very sick, in the very, very high risk patient. At the same time, for the not such high risk patient, our primary aim is quick restoration of pulmonary blood flow. Secondly, to ensure that we reduce pulmonary hypertension. And thirdly, that we decrease the possibility of CTPAH, which, as we all know, can be a horrible, horrible disease. So I think the devices that have been discussed are all very exciting devices. We in India have had limitations. Most of us have still been using a poor man's thrombectomy agent, which is take a large bore sheath in the venous system, rotate a pigtail, and aspirate like hell. You know, it kind of works. We all have anecdotal cases wherein people who came without blood pressures improved, recovered, and kind of went out and are doing quite well subsequently. Some of the devices which are available, we know that the Cath RX is available, and the Penumbra has been a good value add in our armamentarium. Few devices are not yet available, and possibly the Inari Floatriever is likely to be one such device which is going to be easier to handle and is going to have great results. We all know that the capital expense with some of these devices, especially the Penumbra, is high, and many less advantaged cardiac cath labs and less advantaged centers may not have the privilege of using these devices, because you can't really call for a device when you have an emergency. It can strike you at 2 in the morning or 3 in the morning. So and at that time it's kind of difficult to make it available. So one of the ways to think of it is to have institution specific algorithms. We all know that PERT teams and the PERT team approach has been popularized. It is like a shock team, a pulmonary embolism response team is. So I think every institution and a moderate to large size institution, which are otherwise serving as centers of excellence, should devise their own they should devise their own PERT approaches so that we can take this forward. So I think we should ask my other colleagues, Dr. Dilip, and I think Sarita has some experience with using the Penumbra device for a massive pulmonary embolism, and these high-risk pulmonary embolisms. We should hear from them and their experience. We've been using catheter direction by a poor man's innovation, and we have had low threshold to actually start putting patients on ECMO, and that has been quite a game changer for us. So I would welcome Sarita's opinion and also Dilip's opinion.
Thank you, Dr. Dhal. I think today's subject is extremely interesting, and your comments were particularly good. So, I think the treatment of pulmonary embolism always depends. It's an acute emergency, especially when the patient is in shock, when the patient is in hypotension, the patient is desaturating, and the pressures are falling, and you have an acute emergency, and that is the time when we are all worried. Now, the treatment of it frequently in a country like ours depends to which center the patient has presented and whether he has the resources, and also whether that center is equipped with the treatment which the patient desires. Yes, you're very right. In a country like ours, systemic thrombolysis is very frequently used. And I think that somebody's actually posted in the chat box that what's the overall success rate with the current approach of systemic thrombolysis. And there have been studies in which they've reported success rates as high as 78.6% success rate in that. Now, having said that, it's very important to know that there are a whole subset of patients who can't be thrombolized, who have contraindications to thrombolysis. And then there is the other subset of patients who have been thrombolized but have had a failure of thrombolysis. And then the question arises, what do you offer this subset of patients? Because they're in shock and they're deteriorating fast. And that's where the role of catheter-directed thrombolysis comes in. That's where the role of catheter-guided therapies comes in very well. And yes, most of us have been using the poor man system of taking a pigtail in or the other system. But yes, the Penumbra, the Indigo system, is now widely available in India, and a lot of centers have used it. I myself have tried it with excellent results. It's the profiling is very good, and it's very flexible. So it helps you to get where you need to get. But then again, it's an expensive therapy when you compare it with just thrombolysis. And in that shock situation, and when the patient has very little time to decide what he needs to go in with, unless the patient is insured, and asking them to, come up with the costing for this catheter-directed therapy is sometimes very challenging in a situation like ours where the patient pays for everything. But I think these therapies have a great way to go. But at the same time, we have to be very judicious in selecting the right patient for these therapies, because every therapy that we use also has adverse effects. These are all larger bore devices. So it comes with their own risks of bleeding, access site bleedings. Also, when you're manipulating the larger bore devices, you have to be very careful, or you may end up inadvertently damaging the vessels. You might have arrhythmias, you might have clot dislodgement and the complications which occur along with it. So I think also a level of expertise, and there is a learning curve in using of these devices. Having said that, we do have devices now, some of these available in our country. And in situations where you can't thrombolize, or thrombolysis has failed, and your patient needs a rapid dealing with the situation, you could still go ahead, use these devices with good results.
Yeah, so I think it was a very nice overview of the addition of the Euro intervention, the latest Euro intervention volume, and very great insights from Dr. Dhal and Dr. Sarita. So when I kind of analyze all the trials which were presented and the articles were presented, so these were not practice changing, but it has reinforced and reassured us in the same, like the practice which were prevalent earlier. It has re-emphasized the same. Right from the first trial which was presented, monotherapy in patients who had undergone PCI was preferred over NOAC plus antiplatelets. So if we combine these two strategies in patient, even if the patient had a stable angina or a patient in a PCI, they are going to have more of bleeding than the benefit. So risk is more than benefit. So it's still a monotherapy in form of oral anticoagulants in patients of ischemic heart disease post 1 year of PCI, and all those patients who have a stable angina. Now, the second one, which was state-of-art paper of percutaneous treatment of pulmonary embolism, still the systemic thrombolysis enjoys the class 1 indication. Then comes the preferred treatment. Surgical arm is more preferred over the catheter-based interventions. And catheter-based interventions, also, although it looks very impressive, very attractive, all the internists look upon us, look at us to bail them out when they get a patient with pulmonary embolism. But still, at this moment, the kind of guidelines it endorses, they endorse this catheter-based interventions as class 2B indication. And it's appropriate when we see the results of different trials. Although with evolving technologies, we have systems like flow retrievers, we have systems like Ecosonics, we have systems like Indigo, which has penetrated into Indian market and being very commonly used. I can tell. We have used in 3-4 cases with fairly good results. It doesn't give you a kind of more than a perfect removal of thrombus. It gives you a partial removal of thrombus. There is a fair amount of blood loss. The lighting system of Penumbra is still awaited, and basically it reduces the blood loss because there is a catheter-based algorithm that lightning system will start aspirating once it engages with thrombus. So this system is still under trial and it is not available commercially. The only system available is Penumbra 12 French at this moment with Indigo, and then it sucks very continuously, and the kind of amount of suction is huge, and that's why you remove more of thrombus. So these are available options in India. We don't have flow retrievers in India. We don't have Ecosonics in India. We have only Indigo system, and that is really doing well. But at the same time, we don't have evidence. Electronal RCTs, we don't have a very, very strong kind of registry data to endorse it as a class 2 indication. It's still class 2 indication. But later on, maybe in future, it can be it can get a favorable a guideline endorsement. Coming to third topic, which was presented, carotid stenting versus endarterectomy. At this moment, CEA is preferred over stenting when there is a kind of all the reasons, because the stenting can cause, carotid stenting can cause more chances of stroke. And this particular study which was presented, it was not a randomized control trial, evidence. It was a propensity matched, propensity matched trial. And it was a little intrigued to get 265 patients in each arm, or something around 550 cases amongst 1100 patients getting same kind of propensity matched, because we need to see a large amount of population than a small population which comes out with propensity, matching properly with each other. So out of 1100, there's a little critical analysis of the data which is presented in this trial. Out of 1100, they got 550 cases which were divided in two groups, were more or less equal and similar. It's a little kind of intrigue, and it raises some eyebrows. But if we take this as a face value of this trial, so okay, these were propensity match cohorts and the results were more or less equal, then it's very reassuring. Reassuring in terms that 30 days stroke and mortality and myocardial infarction, if it is similar in both groups, it is a very, very impressive piece of evidence which is going to boost carotid artery stenting and giving it the same place which we cardiologists or interventionists look up, kind of scope of the entire.
Yeah.
So, Dr. Dilip, when you were talking about carotid stenting versus carotid endarterectomy, and we did notice that 4 patients in the stenting arm had minor strokes versus 2 in the carotid endarterectomy arm. And out of these 4 patients, 3 of them had filters. So while we know that filters are there to reduce the risk of embolization and stroke, but many a times practically we've seen that when we are deploying these filters, we actually end up with more strokes. What's your opinion about that?
Yeah, I see. When we are doing a carotid artery stenting, a filter is a must. There is, you can't do a CAS without a filter. So probably what they were meaning was, in 3 of the cases, distal filter was used, and 1 case probably a proximal filter was used. So they try to emphasize that distal filters had chances of getting, allowing some embolization to happen. But this piece of evidence gives a result which is otherwise what we have the kind of evidence till now. Till now, the MoMA device, which is a proximal occluder device, the proximal filters, they don't have the same efficacy as what the distal filters are, like spider filter or a Boston's filter. They have a good, efficacy. So in 100% of the cases on carotid stenting, filters are used. And in this trial, they have shown that maybe a coincidence, maybe a chance finding that 3 of them had received a distal filter and 1 had a proximal filter in these situations.
Dr. Dhal, do you always use carotid filter in your cases?
I will take you through some of my previous, shall I say, experience with using protection devices in the carotid. I think the biggest problem which anybody can have is that if you have done a carotid procedure and you've ended up with a stroke and you've not used a protection device, you're going to be in serious trouble. So I'm just reminded, I was smiling because about 15 years, 20 years ago, we used to run a program to train all specialists, whether it was all vascular interventionists, vascular surgeons, neurointerventionists, some neurosurgeons, and some neurologists and cardiologists in carotid stent procedures. We even had the privilege of having a wet lab, an animal lab, and we used to train people as to do carotids. So, frankly, I started my experience with carotid intervention by using the Percusurge device, which came from Medtronic, which is actually a latex hypotube, which gave almost complete occlusion, but they were rather inconvenient to use, so much so that when we used to do patients who had severe or bilateral disease, I recollect some patients who actually had seizures on the table because it used to occlude flow. The filters were a game changer because the filters were easy to deploy. They were something which were convenient to use, but the wiring was not protected because at that time, when you were wiring, there was no distal protection on. And at that time, the world over, vascular surgeons were kind of in a different were in a different team because they used to run down the data coming from cardiologists and some interventional radiologists and neuroradiologists, which is coming for upholding the fact that carotid stenting could be possible. The filtration devices improved over a period of time. Then we realized that we could use proximal protection. Proximal protection, we had 2 devices, the Gore device and, of course, the MoMA device. Unfortunately, none of them are available in India. And now, as far as filtration is concerned, there is a recent technology, not really recent, but a few years, it's not yet available in India. It's called the Silk Road technology, where there is actual flow reversal. So most of the proximal protection devices function on not really creating a flow reversal, but to create an endovascular clamp by which there would be less, shall I say, artery-to-artery embolism, and that would be reduced. And we used a fair amount of MoMAs when it was available, but now we don't have it. So if we get a case, and what has happened also in the landscape is, in the last few years, our vascular surgeons have got access to cath labs. And they have started doing a lot more procedures by themselves. And a lot of more aggressive neurointerventionists and neuroradiologists have also wanted to do carotid. So there was a time that we used to do, maybe a significant double-digit number every month of carotid intervention. Now it doesn't happen like that in a year. So our volumes have kind of come down, I would say, in the last few years. And in doing so, we realize that the head-on-head comparison with surgery becomes even more important. Because when a surgeon does a carotid endarterectomy, in fact, it is very, very enriching for an interventionist to go and see a surgery being done. And I had the privilege, because one of my closest friends was a vascular surgeon. So we used to do our own vascular team. We used to say this patient for stenting, this patient for surgery. And they would use shunts. They also need distal protection. And they have shunts which they put in, and that makes them reasonably safe. And the techniques which are being used, there are many techniques available for carotid endarterectomy, but possibly the eversion technique, the eversion endarterectomy. And really, if we see carotid endarterectomy being done, we would be very scared of doing a stent procedure because the carotid bifurcation is full of atheroma and full of clot when you actually go and see it during surgery. Having said that, because it is convenient to do percutaneous procedures, and our vascular surgeons also learned them. So in places where there was no anatomical contraindication for either of the procedures, that is where the equipoise actually comes. Because if something is classically only for surgery, or something is classically so juicy sitting duct for stenting, we would not like to really compare. But if something is in an equipoise, then we have to take a decision as to what is a better procedure, because we all have done very, very complex carotid procedures, calcific disease, a lot of tortuosity, a lot of challenges, and possibly in those cases it is easier to remember that a 2-inch incision in the neck can give the surgeon a lot of access, and he can do a safe procedure. But sometimes it becomes a challenge of the interventionist mustache, that you say that, okay, listen, I must get this right. But so we must not try, because with the increasing experience with endarterectomy and the increasing success, the increasing availability of shunts, the increasing availability of eversion procedures, unless there's a surgical contraindication, I think a surgical option is not a bad option where the stent procedure is challenging. But where there's equipoise, well, Sarita's question was, would you do a procedure? And I'm reminded of this program that we used to conduct. So we used to have an interventional radiologist. I was the cardiologist, and there was actually a very eminent neurosurgeon who performs a lot of endovascular procedures. And he used to, in every one of our meetings, would say that I actually think that every time you guys use a protection device, you are inviting trouble. And I used to smile at him and laugh at him. And I said, sir, you are one complication away. And it just happened that 2 weeks later, after one of our programs, he probably had a VVIP patient, because he would do a lot of VVIP patients, who had a stroke. And then he got into trouble, because then there were legal connotations. And then he came back to us and said, listen, I need you to show me the protection device a little more, and so that I become a little more conversant. And hereinafter, I will do all my cases only with protection. So, and also when proximal protection came, I realized that he was also one of the first few people to actually start using proximal protection. So it is not that you cannot do carotid without protection. You can, but the risks are those for the patient and also for the interventionist, because the legal fallout of having a stroke, and for the patient and the family, nobody wants a stroke. So therefore, I think we should minimize that. And I would not like to do a carotid. If I had a carotid procedure to be done on me, I would definitely like the operator to use a protection device. So
I have 2 points here. First is, there is a confusion regarding protection devices in SVG, grafts intervention, and carotids. So there are some trials in graft interventions which have shown more of injury to these grafts and the native vessels. And there it casted some doubt on use of protection devices in saphenous grafts. But even then, the recent trial, it was not very old trial, which showed some injury to these vessels. But still, the indication of DPT in saphenous vein graft intervention is class 2A. But still, the penetration of use of DPT in saphenous graft intervention is only 12%. And we all do SVG intervention without graft, without DPTs, and results are more or less similar. But when it comes to carotids, I think this is a risk of stroke is a very, very fatal risk. And there, 100% of these patients, they should receive a deep, distal protection devices, and that is what the guidelines are. So this was the point I wanted to emphasize. And second point was Dr. Dhal was very, very, right in saying that CEAs have got wonderful results, and that is why stenting is not the preferred treatment of choice. It only comes into picture when there is a high risk for CAS. So CAS comes when there is a high risk patient where the carotid stenting is high risk. The patient can't afford to go for a general anesthesia if required, and then his kidneys are compromised. He's a COPD patient, and then stenting is a good option, but still we have high 30-day stroke and MI risk. And that is where this trial was little reassuring. But at the same time, the kind of, the design of the trial was, it was not a randomized controlled trial. It was a propensity match trial. So how much evidence it is going to carry, how much weight it is going to carry, it's little skeptical at this moment, but it's a very reassuring.
I have a lot of skepticism for propensity matched analysis, because as a any true blood evidence-based medicine person would say that this is stretching the limits of statistics and lies and more lies, or somebody likened statistics, medical statistics in this fashion to be like to be taken to an Indian police station. If you torture the data long enough, it will reveal whatever you want it to. So it is like that. But we understand that in selected cases, and that is the approach of the surgeon as well as the interventionist sitting together. And the surgeons appear to have answered that for us because they've started doing interventions. But if we sit together and we decide what places a patient at lesser risk and more gain, I think that is the procedure that we should choose for the patient. But there are going to be complexities. You're going to have patients who are going to have calcium. They're going to have patients who are going to have tortuosity. There are going to be times that you're going to have real challenges that you need to overcome. And there, I think, with due humility and grace, we don't mind some of those cases definitely to be addressed by our surgical colleagues.
I want Dr. Sarita's opinion on this trial, the design of this trial. Out of 1,100 cases, 500 cases were propensity matched, 265 each. 50% of the patients you got to have a kind of same cohort complying with each other. What's your?
You don't need to have the same cohort. So you just select the parameters. It is the touch points that you take. So you can conduct propensity matched analysis even from existing data. And of course, here was a prospective trial which was done. But I have my reservations. Let's hear what Sarita has to say.
I think we still need more evidence before, basically what they were trying to tell us in this trial is that, for ages, it's been that carotid endarterectomy has been preferred. And with the evolution of the devices which have come in and all the innovation in intervention techniques, they were just trying to say that carotid artery stenting is probably good enough. But they didn't absolutely succeed. And I think we still need more studies before we're going to be saying something like that. And but it was still interesting in this trial that, neither of the arms, none of them had any major strokes. The only thing which they had was just minor stroke, which shows how good these procedures, both of these procedures have become over time, and how good our surgeons and interventionists have become, because there was not a single case of major stroke, and which is what we are always worried about when we do these procedures. And also, if you look at the average hospital length, there was barely any difference between the stenting arm and the endarterectomy arm. One was, I think, 3.2 and the other was 3.8. So while the hospital stay was shorter, slightly shorter in the stenting arm, the carotid endarterectomy did equally well. So I think we're still looking for some more data about this, but it's definite that techniques, surgeons, interventionists over
so
time.
I think operator experience is also very important, because
Yes.
if you remember a few years ago, there was this trial called the EVA 3S and the space trial, and there was anybody who had done, it was see one, do one, teach one kind of philosophy, that if you have seen one and you have done one, you were allowed to be enrolled as an operator for the trial. And therefore, the results of carotid stenting were led to a lot of carotid stent bashing. But we need to have reasonable operator experience, and we need to have a reasonable judicious decision making in deciding what procedure we have to take.
Absolutely. And I think Dr. Praneeth also showed one very interesting, he showed a single slide about that, pre-hospital crushing the prasugrel and giving it. We didn't see any further thing about it, but that's an interesting concept where, where you have a very large area of myocardium at risk. That is something which you can always try and give it a faster response, a quicker response. But they didn't follow up with the cardiac MR and see the reduction in infarct size. They just look at the TIMI flow, right?
Yeah, but in the times that we have cangrelor, do you think that we should be doing this crushed ticagrelor, crushed prasugrel, when we have an agent available which can give us a very controlled situation, and also with reasonable algorithms to switch to oral drugs as and when the need arises? I think it can be used if you don't have cangrelor, but if I had a situation like that, I would probably use cangrelor.
At the same time, Dr. Dhal, still we don't have very hard data with cangrelor yet. So
yeah, but there's not going to be very hard data with crushed prasugrel either. Because the so I worked a lot with prasugrel at one time when Lilly was trying to promote Efficient in the country and many parts of the world, and we had some challenges when the drug was being introduced. We felt that maybe 60 milligram loading was a little more than what was required, and at that time we felt that even if you did, and Japan incidentally uses 30 milligrams of loading and 5 milligrams as a regular drug. So but the company insisted on doing 60 and 10, and that's what led to some of the black box warnings, which came initially, and all those about age, weight, and previous history of stroke or TIA. And then once you are crushing and giving this drug in a patient, we do not know the absorption. So we would have to have proof of concept or proof of the pudding before we actually introduce it as a therapy. On the other hand, when we are talking about cangrelor, we are not talking about cangrelor as a standalone agent. Mind you, I'm more of a prasugrel guy than a ticagrelor guy, but I use them almost in given cases. Some patients do go to prasugrel, some go to ticagrelor. But at the same time, there are some inherent advantages when you use a combination of ticagrelor and cangrelor. And those are especially in places where we do not have too much time and we want quick action. Probably that is an easier way to go.
So classically, cangrelor, they said, especially for those patients who could not take oral antiplatelets, or patients who are in shock, or patients who've already been intubated, and we need to take them to the lab and we can't give it to them. So it was classically propagated for those patients. Also, the cost factor is a big thing in India. So I think these issues, and we don't have enough data with cangrelor, and all of us have worked a lot with prasugrel. We know that it works. But what are your reservations about just crushing it and giving it to the patient? You feel that it may not work?
No, we don't have data on the absorption. We don't have data on the. See, please understand that these are patients who are going to be either they are going to be non-compos mentis, or these are patients who are going to be in shock. So most of the thrombolysis trials in cardiogenic shock as well as pulmonary embolism fail because a lot of even intravenously delivered thrombolytic do not act when the patient is in shock. So similarly, oral drugs may have an even lesser chance of possibly reaching appropriate drug levels after being delivered by crushing or whatever. We had a similar paper on crushed ticaglot a few years ago, and if you recollect, I think it came in Uro Intervention itself, where that's about 4 or 5 years ago, and people believed that was the best way to do to save time. We also understand that this would not be a routine requirement, because in most of the other cases, the procedural acts quickly enough and surely enough. So it's only in a given scenario, and in which scenario, like people who are, like I mentioned, and in those patients, probably we need a more controlled agent, like something like Cangalore, maybe a little more controlled.
I think we are exceeding 1 hour of our discussion. Discussions are so interesting, but I had last comment. So it was so encouraging to find that Dr. Dhal uses more of prasugrel. So we
No, I use both of them, but you know, the technical people will kill me if they use more of prasugrel. But the truth is that in patients who've had a problem while on DAPT, in patients who are diabetics, in patients who are STEMI with no contraindication, I would use prasugrel, probably a little over ticaglot. But in other routine stuff, ticaglot, and unfortunately, most of the time, by the time we land up in a case, the antiplatelets have already been given. So those are the times the decision has been taken. I am talking about that select subset wherein you have a challenge. Suppose somebody is comatose. Suppose somebody is in shock, and now you need to deliver the drug before you go in. And that is where I feel that you don't have time to achieve good levels by giving both these drugs, ticaglot and prasugrel, are well absorbed from the stomach in a normal patient. They don't have poor absorption, but we are talking about difficult situations.
Cardiogenic shock patients, yeah. So, but
Yes.
I wanted to say one of my experience. I was enrolling patient in Tuxedo 2 and came out to be a kind of prasugrel arm. And then I had to, it was difficult time for me to find prasugrel in the, pharmacy and in, around pharmacy, pharmacy around my hospital. And I had to, ask the company rep to get some prasugrel tablets for the patient. And then I stopped using prasugrel. I told Dr. Kaul that I can't use prasugrel. My prasugrel arm will be shifted.
My pharmacy doesn't provide it.
Yeah. So I think last comment from Dr. Praneeth, and then we can conclude.
I think it was an exhaustive discussion by all three of you. I don't think there is much to add. I concur with all the statements that have been made.
Sure, sir. So as already mentioned, so the discussions are so interesting that we have already deep down into it. So I think mostly the panel has covered the questions also from, there are 2 questions in the chat box, which has already been covered in the discussion. So I would like to again thank you to the entire panel for this wonderful discussion in our second EuroPCR Journal Club meeting. So to give us the vote of thanks, I would like to call Mr. Anand Chitre. So
Thank you, Vaishali. It's my absolute privilege to cast a vote of thanks to the entire eminent panelists, and it was a wonderful discussion. Your insights, expertise, and this discussion will definitely add a value to many more cardiologists, those who have witnessed, and to share with you all. This session has breached the previous record. Previous we had a 1400 plus live participant, and today we have crossed 2100 participants for this meeting. So I think I congratulate to the entire panelists for their success. This success belongs to you, sir, because, and madam, of course, this is what the discussion, doctor wants to listen. And I think I can't thank enough to the entire panelists. Of course, I also want to thank all the delegates, those who have spared their weekend to listen to this discussion. Thank you so much, all participants. And of course, the team Ajanta, who has percolated the invitations to get those doctors to attend this program. So thank you all once again from my bottom of heart, and I wish everyone good night.
Thank you, sir. Thank you, ma'am.